Welcome to myiacademy.com. I'm Professor Mahfouz Hussain from Pakistan. myiacademy.com is a platform for ophthalmic teaching. In this video, VHB Chapter 7 Section 2b will discuss the treatment of bacterial and fungal keratitis. First of all, the first line of treatment is the commercially available eye drops. Commercially available eye drops are either antifungal or antibacterial. Remember, most ulcers are successfully treated with commercially available eye drops, and most ulcers are bacterial. So what you will be looking for the antibacterial commercially available drops. What antibiotics? Mostly we use broad spectrum antibiotics. If you are suspecting gram-positive cocci, which are involved in the most of the ulcers, then we use cefazolin, vancomycin, and fluoroquinolones. For the gram-negative rods, tobramycin or gentamicin or fluoroquinolones, and for the gram-negative cocci, ceftriaxone, ceftazidime, and fluoroquinolones. So these are the various broad-spectrum antibiotics which are commercially available, and we use them for the most of the ulcers, and we treat most of the ulcers with them. Then are the antifungals. The antifungals are divided into the polyenes, azoles, fluorinated pyrimidines, and echinocandins. We will be dealing only with the polyenes and azoles. There is no subgroup of polyenes, and the prime example is natamycin, which is the only commercially available antifungal. I repeat, in Pakistan, this is the only commercially available antifungal eye drops. Then the other polyene is amphotericin B, and azoles are either amidazoles or triazoles. Commercially available are mainly the triazoles, and the mnemonic is tri-VFP, V for voriconazole, F for fluconazole, and P for posconazole. We normally use voriconazole and fluconazole in this group. And in the next slide, I will tell you the susceptibility of the fungi to these antifungals. And now is the susceptibility of the antifungals. Remember, in areas like Pakistan, Aspergillus and Fusarium are responsible for more than 98% of the fungal infections, so we'll be looking for antifungal which works for both of them. Amphotericin doesn't have a very good susceptibility against these two, so we don't normally use that. Natamycin has got 100% susceptibility, but the problem is it is only topical and it doesn't penetrate into the cornea, so we cannot use them for the deep keratitis which we usually see in the clinical practice. So we are usually left with voriconazole and fluconazole. Voriconazole is the perhaps best one. It has got 100% susceptibility against Aspergillus, 100% susceptibility against Fusarium, and 100% susceptibility against Candida. It's not available in the eye drop form, so we have to make the eye drops from the commercially available injections, and same is for the fluconazole. Fluconazole in the low concentration is not effective against fungi, but in the high concentrations it is effective against Aspergillus and Fusarium. If the commercially available eye drops, whether antifungal or antibacterial, don't work, then we go for the fortified eye drops. What is fortified eye drops? This patient had the ulcer which was not responding, so we made the fortified eye drops, and the ulcer healed. The fortified eye drops means injectable antibiotics are added to the commercial eye drops to make high concentration eye drops. I repeat, fortified means you add injectable antibiotics to the commercially available eye drops to make them of higher concentration, and we call them fortified eye drops, and they are very useful in the treatment of the ulcers. Then is the debridement. Look, this is an ulcer. Your aim is to treat it and to destroy the fungus or the bacteria. So what you do is you debride or you scrape the top of the ulcer, so some part of the ulcer is actually removed. In this way you reduce the load of the fungus or the bacteria, and this is called debridement of the ulcer. Then on the subconjunctival injection, they were very popular but not used nowadays because of the other options. Here you inject a depot of antibiotic or antifungal into the subconjunctival space, and from there it keeps releasing to come to the cornea and then into the eye. The very good option and very effective is the intrastromal antibiotics. Intrastromal means into the stroma of the cornea. Intracamberal means into the anterior chamber, and AC wash means you wash the anterior chamber with the antibiotic or antifungal. Here, look at that. This was the treatment, pre-treatment ulcer, and we injected intrastromal antifungals, and this is after the one injection. So by using intrastromal or intracamberal or AC wash, you can treat the ulcer, which is a very good option nowadays. Some ulcers which are atypical and not responding to the treatment, we can use amniotic membrane. Amniotic membrane is taken from the placenta. Look at the ulcer here and the cheesy hypopyon. We applied the amniotic membrane. This whitish one is the amniotic membrane, and the ulcer healed with this amniotic membrane because the amniotic membrane has got healing properties. Then another option is povidone iodine eye drops. You soak the sponge with the povidone iodine 5% and put it onto the ulcer for 5 minutes, and that kills most of the surface fungi or the bacteria, because povidone iodine kills almost every bacteria or fungus. Another option is PAC-CXL. PAC-CXL is a bit expensive, and here what you do is you use the B12 eye drops and ultraviolet light. You install the B12, which is riboflavin eye drops, onto the cornea, which penetrate into the cornea and stain the fungi or the bacteria. Then you expose the eye to the ultraviolet light, and that kills most of the bacteria or fungi or even the viruses. Look at this example. This ulcer was not responding to any treatment. I did this PAC-CXL, and after one treatment it responded and healed. Then is the keratoplasty. If the ulcer is not responding to any sort of treatment and you're expecting that the cornea is going to be perforated, then instead of waiting, you do the keratoplasty, in which you take the donor cornea and remove the ulcer and put the new cornea in. That is called therapeutic keratoplasty. Conjunctival flap is another way of treatment. This ulcer was not responding to anything. So what the surgeon did, he got the conjunctiva from the periphery and stitched it onto the ulcer, and the ulcer healed nicely after a few weeks. So this is another option which is in your armory to treat the bacterial and fungal ulcers. Tarsography is you close the eye for a certain time, and that helps it to healing. Eye can be closed either directly with a surgical procedure, or you can close the eyelid with an injection called Botox, which paralyzes the lid for 6 to 8 weeks. You have to remember, we don't always succeed and we are not always successful. Here, the infection is so severe that the cornea is perforated at this area and the iris is coming out. While here, in this example, the infection is so severe that the whole cornea got melted and the contents of the eye are coming out. In such cases, you can remove the contents of the eye and only leave the sclera behind, and this procedure is called evisceration. Also remember, in addition to antibiotics and antifungals, we also use systemic antibiotics in severe cases. cycloplegics to relieve the pain because of the ciliary spasm, and topical steroids as an anti-inflammatory agent. And I'll recap the options. These are all the options. You don't use every option in every case, and it depends on your expertise and on your exposure and on the resources available. Like the PAC-CXL is quite expensive, so you cannot use it for every patient. Intrastromal injections and intracameral antibiotics needs a bit of expertise from the surgeons, and everyone doesn't do that. So most of us normally use either the commercial eye drops or the fortified eye drops, and we leave the rest of them to those who are trained in this treatment. Thank you very much for being with me. Thank you.